Welcome everyone to our education session this afternoon. My name is Annette Johns and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador Association of Social Workers. I have the honor of being the moderator for today's education event titled Seniors Mental Health Matters. This is a topic that is of great interest to social workers from across Newfoundland and Labrador as we strive to provide the highest quality services to the seniors we work with on a daily basis, whether it be in long-term care, acute care, or in the community. Understanding the mental health needs of seniors we work with is an important part of our work, and education sessions like the one today enables us to explore the issues and enhance our knowledge and understanding. As of this morning, we had 313 social workers registered for today's event, and I thank you for joining us online. This webinar is a collaboration between the Newfoundland and Labrador Association of Social Workers and the Canadian Association of Social Workers. The webinar presentation will be approximately 60 minutes, followed by a 30-minute questions and answer period that I will moderate. Please send in your questions throughout the presentation, and only myself and the presenter will see the questions, so keep them coming throughout the whole presentation. All the housekeeping details you need, like how to access the recording, where to download slides, and how to get your certificate of attendance are all included in the housekeeping widget that popped up when you first logged in. So I now want to introduce our speaker for this afternoon, Dr. Kimberly Wilson. Kim is an assistant professor in adult development and aging in the Department of Family Relations and Applied Nutrition at the University of Guelph. With training in social work and gerontology, her program of research focuses on improving mental health and well-being for older adults. In particular, Kim is interested in understanding intersections of ageism and stigma for older adults living with dementia and mental illness. Prior to joining the University of Guelph, she was the executive director of the Canadian Coalition for Seniors Mental Health. I had the pleasure of attending one of Kim's webinars when she was with the Coalition, and I'm so pleased that she is joining us from Ontario for this education event today to share her knowledge and expertise. I know you're going to thoroughly enjoy her presentation this afternoon. So on that note, I'm going to pass things over to Kim to begin the presentation.
Thank you so much, Annette, and thank you everybody for joining. I have to say I was amazed that over 300 of you had registered for this, and so I'm really keen to have the chance to have some dialogue with you, although I know it'll be via the chat function. I hope that we can have some time towards the end to chat more a little bit about your interests and what's relevant for your particular practice context. So I was thrilled to receive an email from Annette inviting me to do this webinar, and again, I've tried to keep it as a fairly broad overview about some of the key issues around seniors' mental health, and tried to focus quite a bit on ensuring that you have access to resources so that we can maybe pique some of your interest or answer some of your questions today, but also point you to some really helpful resources, ones that I use in my regular practice, so that if you have questions in the future that you also know where to find some of the best evidence around seniors' mental health. So in terms of sort of what I was hoping we would get done in an hour today, although we can't dialogue over the phone, I would sort of like to get a sense of who's on the line. So I'll tell you a little bit about me and then ask a couple questions about you as well. And then I'll try to present some evidence about what we do know around seniors' mental health and mental illness, and talk a little bit about why it matters. And then spend some time talking about assessment strategies and resources, and a bit around non-pharmacological interventions. And then touch briefly on some of the ethical tensions we may encounter in seniors' mental health and some of the hot topics. And end by talking a little bit about ways to reduce stigma. So, a bit about me. Annette gave you a brief introduction, and I just wanted to expand a little bit. So, I have a background in social work. I did my MSW at the University of Toronto, and from there I was really fortunate to be hired with the Canadian Coalition for Seniors Mental Health. And I was there as the executive director between 2007 and 2013. And it was a really wonderful opportunity to get a sense of the major issues that were happening in the research level, in the practice level, and in the policy level, looking at seniors' mental health. I was working on my PhD throughout the time that I was there and was really fortunate to have an opportunity to join the faculty at the University of Guelph in 2015. So I've been in this role for a few years, but my favorite thing is still reconnecting back with the community where I started my career, which was those delivering care and service to older adults. In terms of my personal experience, because I try to always acknowledge the fact that mental health affects all of us and is personal to all of us, I too have personal lived experiences in my family around mental health and mental illness. I am a caregiver to somebody in my family and who is an older adult and has complex needs. And so I bring my personal experiences into my research and teaching as well. So I would love to know a little bit about you. In the next few slides, there are some poll questions, and I'd love to get a sense of who's on the line today. So I'll be wanting to know a little bit about your sort of comfort and knowledge around seniors' mental health, recognizing that some of you, this might be part of your regular practice, and for others, it may not be. So just trying to get a sense of what the comfort is on the line. And just find out a little bit more about you in terms of how long you've been in practice, a little bit about where you work, and if we can figure out what you're most interested in learning about, and I can try to tailor as we go today. So if you are able to answer what is your comfort or knowledge around seniors' mental health, that would be great. Okay. Just making some notes here for myself. All right, so we've got about 75% who have answered saying that they're somewhat knowledgeable or don't have great comfort. So hopefully that you'll find some good nuggets of information in these slides. And for those who feel, the quarter who feel that they have some good knowledge, again, hopefully this maybe reinforces some of your practice and also introduces you to some other new resources. All right, the next question is then, how long have you been in practice? Okay, lots of expertise and experience on the line today. 100% who have answered the question that I'm seeing here have been in practice for more than 16 years, so amazing. And just a little bit more about what sector you work in, recognizing this won't necessarily be reflective of all the different sectors that you may work in, but if you can just indicate where you spend most of your time in terms of your professional role. Okay, so it looks like we've got a bit more diversity in terms of this one. We've got about 40% working with community supports, and then followed by just over 11% working in long-term care, and also some representation from acute, nonprofit, and then other. Okay, and then last question, in terms of what we're going to try to cover today, if there's anything that you're most interested in learning about. Okay, awesome. An engaged group. Most people are interested in all of it, so that's great. And please do, ask your questions throughout. Probably halfway through I'll pause and just check in to see if there's any questions that would be helpful for us to address before we continue into the second half. And so certainly please do make notes of your questions as you go along. Okay, before we get started, I want to just also acknowledge a little bit about lived experience. So in the presentations that I do in the community and in my own teaching, I always talk about the fact that ideally when we have presentations and sort of experts coming in, that we would have somebody with the academic experience or the practice-based experience that I'll be bringing today, but that we also would have a co-presenter, and that's somebody with lived experience. And recognizing that that's not always practical or feasible, and it also asks a lot of older adults, I'd just like to acknowledge that if you're thinking about doing training or education events in your own local regions, when and if you can bring in people with lived experience, so older adults with lived experience of mental illness or those who have cared for somebody with a mental illness, that lived experience is equally important as the academic or practice-based experience. And towards the end, when we talk about reducing stigma, we know from research through the Mental Health Commission of Canada and others that the most effective way to reduce stigma is to have a social contact intervention, and that's somebody with lived experience there in the room. And so ideally, in a perfect world, anytime I present, I would have with me an older adult with lived experience. And so at the end, we'll see a clip from Rosalind, who's an older adult that I worked with for another project, who recorded her story as a part of a way to try to create some sustainable ways that we can always ensure older adult voices are in the room when we do presentations. So just thinking about your own future training and education, when and if you can, to ensure that we are including the voices of older adults in our research and presentations. Okay, I always like to try to get started with some definitions, and again, likely this is a refresher for most folks on the line. But certainly in my teaching, I always, sorry, I'm just seeing that we're asking for a little more time with poll questions here. So I apologize if folks didn't have a chance to weigh in on the poll. With the next ones, I'll make sure that there's a little bit of time. So in terms of language, to me, language is a really important piece of working against stigma, but also myth busting. And so I always try to be really careful in the language that I use, although certainly I'm not perfect and don't always, speak the way I hope that I would. But want to always be clear about mental health and mental illness and how we often use those terms interchangeably. And yet I think it's really important that we talk about what the differences are between the two. So I quite like the Corey Keyes model that talks about mental health as being distinct from mental illness, and each is on a separate but intersecting continuum. So historically, we often talked about mental health as the absence of mental illness, but in fact, one of the messages that I always try to impart is that we all have mental health, and that's regardless of whether or not we're living with symptoms of mental illness. And so in all of our work, we can always aim to be promoting mental health so that we can help folks flourish. And where those folks are having trouble with their mental health, where their mental health may be languishing, thinking about what interventions we can put into place to help, again, move them along that continuum closer to flourishing mental health. And mental illness, regardless of whether or not you live with a mental illness that is managed or is fluctuating or is perhaps in acute crisis, there's things that we can do to also encourage good mental health. And so, again, with my students, a lot of them haven't sort of thought about this concept that even somebody who lives with severe and persistent mental illness, they can actually have really good mental health. And vice versa, people who don't have any active symptoms or diagnoses of mental illness, there's a lot that we can do, there's a lot that happens for people where their mental health may be languishing. So thinking about them as related but separate concepts helps to think a little bit more about the types of interventions we might put into place. This definition comes out of the Chief Public Health Officer's report, and again, I just sort of like this because it reiterates about how we all have mental health. It's the capacity that we all have to feel, think, and act in ways that enhance our ability to enjoy life and deal with the challenges we face. And important to recognize that all of our mental health fluctuates. We have good days, we have bad days, and depending on what's happening in the world around us, some days it's harder than others to deal with the challenges that we face. But there's a lot we can do with older adults to help build some of that mental health in folks. And then vice versa, opposite to that or related to that is that mental illnesses, and again, whether or not you sort of like the diagnostic language, but we talk about mental illnesses as really some changes in thinking, mood, and behavior that have a significant distress and impair functioning. And I always say that with older adults, we often should be focused more on function rather than diagnosis. And that's because it gets more complex often to tease out what actually might be the diagnosis or the reason why somebody is experiencing changes in their mood, thinking, or behavior. But what we want to do is work to help them maintain or enhance or optimize function so that they continue to have quality of life as they age. So with that, when we talk about who it is that is considered our population of interest when we think about seniors' mental health or mental illness in late life, I think it's important to recognize that we have some significant variation in the profile. So we're actually in an interesting period of time where we have people aging with a lifelong mental illness. And in fact, we are sort of experiencing this for the first time with some of the more severe and persistent mental illnesses. We still know that there is a discrepancy between life expectancy, for example, people living with schizophrenia, but with the changes that we have in treatment and intervention and management, we're seeing people live longer, as we are seeing across the general population as well. So we actually have a new generation of people living with and aging with mental illness. And we also have people who have had episodic or acute mental illness throughout their life, depression, anxiety, and again, as they're aging, some of the ways that their symptoms may manifest or some of the ways that they may manage their mental illnesses may shift with age. We also have people who may experience a mental illness for the first time in late life. And so they may not have had interactions with mental health professionals. They may not have comfort or experience talking about their symptoms or the changes that they're experiencing. And so as they're growing older, this is a new challenge that they're having to navigate. We also have people living with cognitive impairments. And again, my personal belief, which is not everyone's, but my personal belief is that when we talk about mental illness, we should be considering cognitive impairment in that same umbrella. But for some folks, they may have their primary diagnosis or concern as a cognitive impairment, and now are experiencing some comorbid challenges with their mental health or also experiencing symptoms of mental illness. And similarly, they may be people whose sort of primary concern or diagnosis is a physical condition, and then they're having comorbid mental illness. So, for example, when we look at chronic heart disease or cardiovascular events, we know that there are correlations with depression as well. So again, folks who are navigating a change in their physical health status, and it's now having a relationship on their mental well-being. All of this to say that there's a lot of diversity when we talk about seniors' mental health and mental illness. That plus, again, likely folks on the line are familiar with this, but thinking about the diversity of late life in general. So we typically talk about seniors or older adults as our arbitrary cutoff of age 65, but recognizing life expectancies, we're talking about people who are in their 60s, 70s, 80s, 90s, and centenarians as well. So we've got a very large group of people who all get labeled as older adults. And then plus we think about diversity around culture and ethnicity, and in particular giving specific thought to cultural context and cultural beliefs about mental illness, which we know shift depending on context. And then we layer in different social locations and gender and race and religion and sexual orientation and socioeconomic status and all of those different social locations and social determinants of health, which will impact and influence the way an individual experiences mental illness in late life. I think it's also important to note that we have some cohort differences around knowledge and understanding and acceptance of mental illness. Certainly in the teaching that I do now with undergraduate students, their experience and comfort and exposure to mental illness is very different throughout their lifetime than somebody who is currently in their 70s or 80s. And so recognizing that the people we might be working with or supporting may have grown up in an era where we didn't talk about mental illness, where in fact some of the treatments that we had for mental illness weren't terribly humane. And so thinking about the historical legacies of that stigma and the treatments that we had and how that influences somebody's current understanding or comfort when they think about mental illness is really important to consider. And then, of course, the intersection of all these diversities really highlights for us, again, how every individual that we work with who is an older adult will bring their own unique social and historical and cultural context with them. So in a lot of the work that I do, I often open it up to have folks sort of guess what the top concerns are when it comes to thinking about mental illness in late life. And often folks will, highlight that the big concerns that they hear about are dementia. And while that's certainly true, I always like to remind folks that, in fact, depression is the most common mental illness that we see with older adults. And certainly we're seeing more and understanding more about anxiety in late life. And we're going to spend a little bit of time also talking today about delirium. So in terms of, the most common or the top concerns, those are the ones that certainly come to mind. And the other thing that we have a lot of folks ask about is, how do we know what's actually typical aging? What is expected of somebody as they grow older versus what are signs and symptoms that somebody might be exhibiting changes around their mental status and considering mental illness. And this is a place where I think that stigma and ageism can actually complicate our understanding about what is typical aging versus aging with mental illness. So although depression is the most common mental illness in late life, one of the key messages we always try to reiterate is that it is not a typical part of growing older. And yet we do know many folks are told when they go to seek help that, it's not surprising that perhaps your mood has changed. You're recently bereaved, you've moved out of your family home, your kids are far away. That's part of growing older. And while the intention is often to normalize that these transitions are hard, sometimes it reinforces the message that changes in mental status and mental well-being are an expected part of growing older. So we really want to refute the myth that something like depression and or dementia is a typical part of growing older. So in the next few slides, I'm going to try to present a little bit about what we do know around seniors' mental health and mental illness. But I also, before we do that, want to point out that there are some gaps in our data. So we've got better data than we have had, but a lot of times when we look at research and some of our foundational research in this field, folks over the age of 65 weren't included in research studies. And when we look at some of the community surveys that we'll take a look at, there are some groups of older adults who are systematically excluded in those surveys. And I also think it's important to consider that some of the health surveys that we have, when they're asking people to self-report on their mental health and their mental illness, I'm always concerned that we're missing a group of folks who are at their lowest in terms of their mood or well-being. Because, any of us who've had a really bad day or our mood is so low that it's hard to get out of bed, are we also willing to participate in research or surveys where we're counting or trying to determine who's living with mental illness and their mental health status? So some of the data, I would say that there's some caution to it and we need to interpret carefully. And so just point out some of those pieces as we go through today. I also argue, too, that we have to be really careful in terms of the data that we use to make sure that the measurement that has been used is appropriate. So, for example, with depression, we know that symptoms of depression can manifest differently in older adults than in younger populations. And so are we using tools that are sensitive enough to pick up on those who are truly living with symptoms of depression? And so again, we do have some data, but I always sort of caution that we have to be careful in terms of how we interpret it. So we do have some new evidence that I wanted to point out because it might not be some that you have seen before, but the 2017 Commonwealth Fund's annual International Health Policy Survey was released recently, and it focused on the views and experiences of seniors in 11 developed countries, Canada being one of them. And what I found interesting out of this is that 1 in 5 Canadian seniors in this survey said that they experienced emotional distress in the last 2 years, which they found difficult to cope with on their own. And I actually sort of like the way that question was framed, because it's not necessarily about whether or not someone has a diagnosis of a mental illness, but it's instead talking about the fact that folks were having challenges that were hard to manage on their own. And a lot of times when we are talking about seniors' mental health or geriatric social work, we're talking about the fact that we work with an older adult, but also their circle of care. And I think it's really important here to note, 20% are finding it hard to cope on their own, and who are the folks that they are able to rely on to help them cope. And in particular, what about the folks who don't have somebody to help them navigate these challenges? So certainly there's a lot of folks that are relying on others to navigate the challenges that they're facing. Within this, 14% also said that they had depression, anxiety, or other mental health concerns. And that was slightly higher than what was seen across the other Commonwealth countries, which was 12%. So again, it aligns, closely with the stat that we say in any given year, 1 in 5 Canadians will have a challenge with their own mental health or experience a mental illness. But there's some data that has said that that rate is lower in older adults. And I think here we're seeing that while it might be slightly lower, it's still certainly enough older adults. And when we look at how many older adults we have in our aging population, that there is still a real imperative here for us to be paying attention to seniors' mental health and mental illness. We also have some very exciting new data to be able to understand a little bit more about the health and well-being of our aging population. Some of you may have heard of this before, but we now have data from the Canadian Longitudinal Study on Aging. It's the largest and most comprehensive research platform and infrastructure available for aging research, and over 50,000 Canadians participated in this. At baseline, when they were recruited, they were the ages 45 to 85, and they're going to be followed every 3 years for at least 20 years. So really exciting to have this new data. And for any of you who may have research as part of your portfolio, or if you're supervising students who are interested in research, this is an incredible wealth of knowledge. There is data on everything you could possibly imagine. So lots of questions will be able to be answered using this data. Right now, the data that is available for analysis is only the baseline data. So the first measurements from folks right when they started in the study. And in May of 2018, the first report on health and aging in Canada was launched. And this is reporting on the baseline data from the sample of 50,000 plus. So this is the cover of it. It's available on the CLSA website, and it's got 12 different chapters sort of summarizing the key findings in these different areas. So mental health, to social isolation, to some overall demographics about the sample, some really great information in here, and would encourage any of you to look at what's happening in this report and keep an eye out for future iterations of this report when we have some of the follow-up data. So just very briefly in terms of what came out of the baseline data, what was exciting to see is that most participants reported their mental health as excellent, very good, or good. And approximately 5% reported fair or poor general mental health. And this proportion, interestingly, declined with age. And what we found, or what the authors of that chapter found, is that the youngest participants reported the greatest concerns with their mental health. And so those would be more of the midlife sample, thinking about the youngest participants being age 45. In this sample, women tended to report more depressive symptoms and psychological distress than men did, so also important for us to be considering sex and gender differences in the work that we do. I think here, too, is a place where we need to be a little bit careful with the interpretation of the data. While it is intended to be a representative sample, again, I sort of wonder about the intensity of what folks are being asked to do to participate in this study, and if those with the lowest mood or mental well-being are actually able or interested to participate. So I always sort of caution that this is probably an underrepresentation of the current state of mental illness. And that said, what's going to be really interesting is we'll be able to now do some follow-up. So these same participants 3 years later, 3 years older, are we seeing those similar patterns? Also, I think interesting to note from this chapter as well, authors reported that one of the measures of depression that they used, which is the CESD, women aged 75 plus responding in French were actually the largest group screening positive for depression. So interesting too, they are only collecting data in English and French, but interesting again to see some of those potential considerations. And I think another important piece when we think about mental health promotion and social isolation and loneliness is the fact that the likelihood of screening positive on this measure of depression was higher among those who reported being lonely. And there's been a lot in the news recently, you may have seen, talking about, loneliness being as bad for you as smoking. And so when we think about the relationship here between potential social isolation and loneliness and depression, important to say it's not causal, but I think that there's some opportunity here for us to be targeting some of our mental health promotion and outreach to those who might be reporting being lonely as they grow older, as a way to potentially, again, focus on that flourishing mental health, helping people feel engaged in their communities, to try to do a little bit there in terms of the prevention around depression. I also wanted to point out a little bit more about diversity and some of the data that we do have from the CLSA. And I had the opportunity to co-author this chapter with Dr. Arne Stinchcombe out of Ottawa. And we had the opportunity to analyze participants who identified as lesbian, gay, or bisexual in this sample. And at baseline, there wasn't a question on gender identity, so we're only able to speak to sort of lesbian, gay, bisexual participants without speaking for the whole LGBTQ plus community. But I think it's interesting to note that at baseline, about 2% of the sample identified as lesbian, gay, or bisexual, so that's just over 1,000 participants. And female sexual minorities had a higher lifetime prevalence of anxiety disorders, mood disorders, and also poor or fair current rated mental health relative to their heterosexual peers. And this was after controlling for some of the demographic characteristics that we think might confound that finding. And similarly among the males, that there were greater odds for gay and bisexual men of previously being diagnosed with an anxiety disorder and a mood disorder, and again, after controlling for those demographic characteristics. So I include this just as another reminder about how important it is to consider the social and historical context of the older adults that we work with, and recognizing that these diverse identities and social locations and intersections are really important for us to consider when we're working with older adults who might be experiencing challenges with their mental health and or symptoms of mental illness. I also wanted to just highlight some interesting findings from the Canadian Institute for Health Information, and this comes from their continuing care reporting system. And this is quick stats. So again, we just have to be careful because it's a snapshot in time in a 1-week period. But to me, it still paints an interesting picture. So from this, they get data from residential-based continuing care facilities, so long-term care homes or nursing homes is the language we often use. And this does, for your own context, reflect data from Newfoundland and Labrador, along with Nova Scotia, Ontario, Manitoba, Saskatchewan, Alberta, BC, and Yukon. So in this quick stat, there's data from just over 180,000 residents, and of those, 57% had some depressive symptoms or possible depressive disorder. And so again, this aligns with some of the other data we have, a 2011 report out of the Canadian Institute for Health Information that found about 44% of residents had symptoms of depression or a diagnosis. We've actually seen that go up a little bit in this particular sample. And yet, when I think about the role of social workers, only 0.7% were receiving psychological therapy. And again, this is a snapshot in time, so it's not necessarily representative of any of their experiences with psychological therapy. But almost as many folks were on an antidepressant as those who were showing signs of depression. So I think, too, there's some good evidence for the non-pharmacological treatments that will support folks living with depression. And when we think about the different contexts where older adults are living, I think there are some discrepancies in terms of how much psychological supports are available to older adults compared to sometimes the frontline action of medication, which again has very good evidence, but thinking about what we as helping professionals may be able to do, I think there's some really nice opportunities here for us to be enhancing our practice in settings like long-term care. In August, we had a new report too coming out of Statistics Canada, and again, this one is focused on life satisfaction among Canadian seniors, so a little bit more on the mental health promotion or the mental health side versus the mental illness side. But again, here we see that 45% from this sample stated that their general health was excellent or very good, and that their mental health, 61% said that their mental health was excellent or very good. On the other hand, I think it's important to note that 20 and 6%, so a quarter of the sample, stated that their general health and mental health were fair or poor. So I think it's a good news story that a lot of people are doing very well, but I think it's also really important that we're acknowledging that we've got a very large population of older adults, and if a quarter of them are having challenges with their mental health, self-rating it as fair or poor, there's a big opportunity here for us to be working on mental health promotion. And in this particular data, the proportions were similar for men and women. Just also want to point out another data that came out, some other data that came out of Stats Canada, and for me, I think it's interesting to be thinking about measures of resilience and mental health. And when we think about mental health promotion, that ability to sort of bounce back and respond to difficult challenges that we may experience, these ideas of resilience are really important. So this particular study used data from the 2016 General Social Survey on Canadians at work and home to provide a recent assessment of life satisfaction of seniors in Canada. And again, what we see here is some really interesting questions that we can think about asking or incorporating into our social work practice to try to draw on strengths and elicit experiences of resilience. So in terms of having a hopeful view for the future, having enough energy to meet life's challenges, being able to continue about your life the way you normally do, even after difficulties, some nice clinical type questions that we're actually seeing now having an evidence base for them as well. So I just want to highlight a couple other considerations here. As I mentioned earlier, that although depression is the most common mental illness in late life, we always want to make sure that we're doing this enlightened opportunism, which is, fighting stigma and dispelling myths at every opportunity we have, and reminding folks that depression is not a typical part of growing older. And in some of the measures that we have, we may see an underreporting because older adults, again, are less likely to report depressed mood, and so we need to use assessments that are appropriate and have appropriate psychometric properties to capture symptoms of depression in older adults. And again, some unique cohort effects when we think about our oldest old and their experiences and comfort thinking and speaking about mental illness throughout their life. And another key message is that we really want to remind folks that with appropriate assessment and then intervention, there's actually some very good evidence around success rates and recovery from depression in late life. I'm just going to go through two other slides here, and then I'm going to pause to see if there's any questions. But I also want to point out some other sort of hot topics, concerns in seniors' mental health. And One of the big ones that surprises a lot of people, because it doesn't get the same attention as other age groups, but is actually about suicide rates in late life. So the most recent data that I sort of check every year when I'm teaching this to my students, that's the SASCAN data from 2009 reports on suicide numbers and suicide rates. And when we look at older men, particularly those over the age of 80, they have the highest rates of suicide. And yet the numbers are quite low because, again, there aren't as many older men. But when we use the measure of rate, it is quite high and something that warrants quite a bit of attention and focus. We're going to talk a little bit more about delirium as well, but I think it's really important for, I think it was 11% of you or 8% of you working in acute care. Certainly delirium is something that is very common and warrants particular attention in acute care, although we also, of course, see it in the community and in long-term care. But nearly half of seniors who will go into acute care will have an experience of a delirium. And we'll talk a bit more about delirium, but for those who are not as familiar with it, delirium is an acute confusional state, and it's considered a medical emergency. But what is really challenging is when an older adult goes into acute care, and if there isn't somebody there with them, or if they don't have familiarity with the providers, the symptoms of the acute confusion that they may present with are often mistaken for a cognitive impairment, and therefore sort of the acuity isn't noticed, and the potential treatments and interventions are not provided, and therefore the delirium symptoms may continue. So the hope is that we're raising awareness about delirium so that it is treated as a medical emergency, and for many folks, their symptoms of delirium will go away. They will go back to their typical baseline. And so it's really important that we're paying attention to delirium in acute care. And there's some interesting evidence, too, about hospitalizations for folks. So 20% of hospitalizations of people over the age of 50 are due to problems with medications. So again, we're seeing a lot of complexity around polypharmacy, and many of those having to do with mental illnesses. And so, thinking about that complexity as well and the older adults we might be working with. And then just in terms of some of the more stats to be throwing at you, again, just this summer there was another report coming out of the Canadian Institute for Health Information around dementia in Canada. And we know in 2010 we had the very influential report called The Rising Tide that came out of the Alzheimer's Society of Canada. We know that if something doesn't change in our system, our rates of dementia will continue to increase with our aging population. And this was reflected in this report where they found that the number of seniors with dementia increased by 83% between 2002 and 2013. And approximately 76,000 new cases are diagnosed every year. And I think it's interesting to note that only 3% of those are sort of early onset or young onset, so folks under the age of 65. What came out of this year, too, is that a major crux of the report is that the unpaid caregivers of older adults with dementia are more likely to spend time providing care and experience distress when we compare with caregivers of other seniors. And I think, too, if we're taking a health systems perspective or a policy perspective, this is a really important consideration because that caregiver distress can often be a tipping point in terms of a person with dementia then requiring higher levels of care, including residential care. So I'm just going to pause here and just check in maybe with you, Annette, to see if there's any questions that would be helpful for us to get into before we move into sort of the second half of the presentation here.
Yeah, there was a couple of questions there, Kim. One person was looking at, I guess, the slide that talked about the antidepressants and 50% being on antidepressants. And if you have a perspective to share on how this compares to the younger population with regards to medication rates, and also are a high percentage of seniors who are medicated in care or living independently? So good questions. I'll be upfront with what I don't know. So I don't know the medication rates in younger populations. That's a great question, and I can see if I can do a little bit of research to report back, but I don't know that.
The nice thing about this data set is every resident then is screened with certain questions. And so in terms of the way we get this data compared to how we would get data for younger populations if they're not in residential care, I don't know that we have that same comparison. And sort of my answer is similar then for community dwelling older adults in terms of, again, the way this data is collected is very systematic. I do think that there are folks, Andrea Grenier comes to mind in Dallas Sites, there are researchers who will sometimes link administrative data in terms of the provincial insurance health plans and then the provincially funded drug benefit programs for older adults. So there is, I believe, some data looking at community dwelling older adults and rates of medication use, but I don't have those numbers in front of me, so I wouldn't want to say the wrong number. But I would say that those are some names of folks who you might want to look up who I believe have done research in this.
Okay, thank you. You also talked about how depression is manifested different in older adults. Can you give some more information on that?
Yeah, absolutely. So I think this is a place where it'll be interesting, in my perspective, to see if this changes as we have sort of different societal acceptance and understanding around mental illness, or if it really is truly related to age. But we often find that, a younger person will go in and use the language of I'm feeling depressed or my mood is low. And when older adults go in typically and seek help, they're more likely to report somatic complaints rather than speaking specifically about their mood. So we'll come in more with sort of pains or changes in their, social context versus actually speaking about their mood. And so there's an acronym, SIGI-CAPS, that we suggest that folks use when working with older adults to try assess for some of the differences. And it helps us to point out, again, how it might manifest differently. So again, I'm just trying to see if I had included that later on in the slides, but the biggest piece is paying attention to the somatic concerns. So, the aches and the pains, and thinking about changes in appetite and changes in sleeping and a loss of interest rather than necessarily reporting specifically on feeling depressed or low mood.
Okay, thank you. And before we move on, we'll just do one more question. Any sense, and then we'll come back to the other questions, any sense on why men 80 years and older have the highest suicide rate in Canada?
Yeah, it's a great question. So again, I'm going to refer to the names of some of my colleagues who are experts in this area. So Martin Heisel is a geropsychologist out of Western University, and much of his work is focused on late life suicide prevention. And I don't think that the evidence is there in terms of why, but we do know based on the evidence that we have that there are particular risk factors that include sort of age and sex, but also in terms of personality factors, medical illness, negative life transitions, functional impairment, and family history. And I've heard folks hypothesize, but I'm always very careful because I think this is just sort of hunches that people have, that perhaps, again, when we think about sort of current cohorts of older adults, and if we're thinking about primarily heterosexual older men, that potentially after, the loss of a partner and in terms of activities of daily living and sort of sense of purpose and meaning, that some of those, particularly after the loss of a partner, can make it more challenging for men. But there's also been folks that hypothesize also about access to means, that particularly for some older men, having more access to more lethal means like firearms. So what we do know from our evidence is that there are more attempts than completed suicides for older women, and the lethality of attempts for men are that, there are more completed suicides than attempts. So I think that it's multifactorial. There's a lot of sort of reasons, but I think too when we look at some of these ideas about gendered roles and masculinities and health help seeking, that all of that has some influence, but of course always really careful to not make assumptions. Yeah. The tricky thing about suicide in late life, the research, is that we have some research, but it's very hard to have prospective research. So much of the research we have on suicide is retrospective. And so, again, it sort of changes the amount of data that we have and the way we can understand and interpret the data.
Okay, thank you. That was really helpful. So maybe we'll continue on with the presentation, and
okay.
There's some other questions coming in. We'll get to those later on as well.
Okay, great.
Thank you.
So I'm actually not going to spend a lot of time building the case for why it matters, because I have a feeling that most of you on the line have, as social workers, as folks who may be older yourselves, who have aging family members and people you care about, I think we can all sort of appreciate and understand why it matters. And I think, too, we can make a case based on some of the evidence. So if we wanted to take that sort of sometimes the return on investment is a little bit more of a challenging argument, it feels like, with older adults. If we only have so much money, we focus on, younger people because they've got longer to live. But I always argue it matters no matter what age you are that we can think about your mental health and well-being. And where we do have some of our best evidence and where we see rates quite high is in long-term care and seniors' residences. And so again, while it's only a small proportion of older adults who live in institutional care, the majority of those living there are experiencing some challenges with their mental health and their mental illness and cognitive impairments as well. So there's, I think, a moral and demographic imperative for us to be thinking about older adults in long-term care. But we also have some evidence coming out of a report done for the Mental Health Commission that the rates of mental illnesses for adults between the ages of 70 and 89, and this includes but is not limited to dementia, is actually projected to be higher than for any other age group by the year 2041. So again, a lot of times we focus more on mental health and well-being in younger populations, and I think this evidence really helps to build the case that we need to think about mental health across the age and lifespan. And again, data that came out of the Mental Health Commission of Canada that shows us that more than 1.8 million people over the age of 60 had a mental health illness or problem, so in that given year. So again, I think we are starting to get the evidence that helps us to build the case for saying why we do need to pay attention to seniors' mental health. I think too, and I'm not sure how much this is relevant in your province, although I suspect it's true everywhere, but certainly coming from the Ontario perspective, there has been more of a focus on long-term care, and that's related to the fact that we're seeing more of these responsive behaviors typically associated with a mental illness or cognitive impairment, and that those are the behaviors that for family members, for the individuals themselves, and also for care providers can be the most challenging to work with. And so we've changed the language to focus on the response, recognizing that every behavior has meaning. And in our province, in Ontario, there's been significant government investments through a program called Behavioral Supports Ontario. So recognizing that we actually need to build capacity in the care system and amongst care providers to best manage and support people with responsive behaviors. And those are ones that we might have previously called behavioral or psychological symptoms of dementia. So that might be the agitation, the aggression, the sexual disinhibition. And again, when we look at the complexity and the acuity of care of folks living in long-term care now, we are seeing a lot of responsive behaviors. Much of the investment in Ontario came from high-profile cases, and certainly that has spread across the country as well. So a few years ago, the W5 on CTV did a report on violence and deaths in long-term care, and it was a fairly high-profile piece that really picked up on the fact that we are seeing, because of the complexity of behaviors in long-term care, we're seeing sort of the worst-case scenario with some of that is resulting in violence and death. So again, I think these high-profile cases have really helped to, certainly in Ontario, and I know that's spread across some other provinces, build the case for why it's an important investment to be making. Probably the most important, or one of the most important things that we do as geriatric social workers is to support the differential diagnosis between the 3 Ds. And again, mentioned a little bit about delirium before in terms of it being an acute confusional state, and we might see the hypoactive type where people are lethargic and unresponsive, which sometimes can be seen as a depression. Or we may see the hyperactive type of delirium where people are aggressive and seeing hallucinations and agitated and in acute care trying to pull lines out, which again sometimes gets seen as more of a responsive behavior associated with the dementia. And then again, we know how common depression is in late life and along with dementia, which now, if we use the language out of the DSM, now is labeled neurocognitive disorder. So just as sort of an interactive piece, trying to get folks to sort of check in on folks in terms of your knowledge around these 3 Ds, if you want to weigh in on which of these you think might be most represented by the symptoms that I've got on the next few slides. So if we see symptoms fluctuate during the course of a day, do you think, based on your knowledge around the 3 Ds, if that might be something that is indicative of a delirium, a dementia, or a depression? And I'm going to open up the poll here for you to do that. Okay, great. So we're seeing here, hopefully that's enough time for folks. I think the results that we're seeing here are really reflective of how complex that is in the real world too. So we've seen about 44% of folks indicate that that's probably a sign of delirium, but another 40% sort of acknowledging that that is true of dementia too. And certainly for folks who support older adults living with dementia, you may sort of be aware of a phenomenon called sundowning, where we see behaviors start to change later in the day. But we typically talk about the fluctuating symptoms as being more indicative of a delirium. So coming on really suddenly, and if we were to assess throughout the day, we might see changes, which might help us to see that that is actually a delirium. So I think these poll results show exactly the challenges of why this requires specific training and expertise, and why hopefully for some of you on the line, this is something that you'll continue to sort of think about in your practice around these 3 Ds, because it takes those who have expertise in geriatrics to help clinical teams sort through those 3 Ds. Here's another one for you. If an individual has a decreased appetite, what might we think that this is a sign of? Delirium, dementia, or depression? Okay, great. So this one we've seen pretty significant agreement on that this is a sign of a depression, and absolutely, especially when we use our mnemonic of SIGI CAPS, appetite, decreased appetite in particular, is a strong sign that we might be seeing symptoms here of depression. And one last one, if an individual shows signs of hoarding, what do you think that one is? Great. So again, here we're seeing some good agreement on a dementia, and that's certainly true. Sometimes we see that one of those sort of responsive behaviors, or one of the behavior changes that might accompany a dementia, is signs of hoarding. That said, certainly for those in the community that we might be working with, if we're seeing signs of hoarding, absolutely we're investigating depression and anxiety as well. But just to sort of show how some of these symptoms are certainly true across all the 3 Ds, but we also might have some little tips and tricks in terms of how do we support others in terms of the differentiation process. So what I wanted to do in the next few slides is just give you some strategies and resources around assessment. And when I think about the role of geriatric social workers, a big piece is that assessment and becoming the experts in terms of the geriatric syndromes. So what I wanted to point out, there's a nice overview textbook for any of you who are working with students or supporting students or want to sort of have an overview yourself of some of the common social work roles with older adults. That's the Social Work with Older Adults book there by Kathleen McInnes-Dittrich. One that I use quite a bit in my work is the Handbook of Assessment in Clinical Gerontology. It's a big, thick textbook. It has not been updated yet to align with the DSM-5, but some really helpful, quite a compendium of different assessment resources and tools that you can use for any of the geriatric syndromes or concerns. My experience is, although there have been some changes in the DSM-5 that are relevant for older adults, that they have not really influenced a lot of the assessment tools that we use still. So to me, it's still a relevant handbook there. And then, of course, whether or not that aligns with your social work perspective, many of the environments that we work in still have sort of eligibility criteria for service and for funding based on labels and diagnoses that come out of the DSM-5. And again, there were some important changes between the DSM-4 text revision and 5 in terms of relevance for older adults. One being, for example, there used to be a clause in terms of risk for depression and sort of recent bereavement, and that bereavement clause is no longer something that we consider in terms of the temporal period for symptoms of depression. And also in terms of the way we now classify a delirium and dementia, we now talk about the language of neurocognitive disorders according to the DSM-5. So these are some really nice overview resources that if this is a newer field to you, or if you're moving into a new role somewhere else and you're working more with older adults, these are resources I would recommend in terms of having a lot of great background information. I am biased, of course, because I used to work with them, but also in terms of where to go for some of the best evidence around seniors' mental health. I can't speak highly enough about the Canadian Coalition for Seniors' Mental Health. They, in the era that I was there, and they continue to do this, but they've created interdisciplinary clinical best practice guidelines in the areas of depression, delirium, late-life suicide risk and prevention, and also mood disorders and behaviors in long-term care. So really nice, thick, hardy clinical guidelines, many of which have been updated with the best evidence, but also recognizing that those are a little bit lengthy for some folks. They have clinician pocket cards, and for those of you who are particularly interested in late-life suicide prevention, they've got a nice toolkit, which also includes DVD, which you can actually view online as well. That's certainly I use it in my teaching and training. It's a nice resource to walk through some of the risk factors and the ways we might support those showing signs of suicide risk. This is another one that I feel like is not as well known in the Canadian context, and yet I find it to be really helpful. These come out of, it's the Consult Geri series, and it's the Try This series, and when you go into their website, and I've included the links here, they have a sort of a general assessment series for older adults. The state has some really incredible funding and resourcing to support helping professionals working with older adults. So the Hartford Geriatric Initiative is focused on nursing, but many of the tools that are used in this series are ones that we also know that social workers will use. So, for example, this gives you a snapshot of what you would find if you were interested in working on your assessment skills around delirium. The most common assessment tool we would use is the confusion assessment method, and they've got a nice description on it. You can download a PDF, which is typically a 2-pager, and the front page gives you the information about the tool, including the psychometric properties, so the reliability and validity, and which populations it's most appropriate to use with. And then the back has the actual assessment tool, so the pen and paper tool, in terms of what you would use. And then, as you can see on this slide, each one has a video as well, where an actual older adult, not an actor, so an actual person showing signs and symptoms, it goes through the assessment tool with nursing students and professionals. And so again, if you're moving into a new agency and you're being asked to support some of maybe the hospital elder life program where you're doing some assessments around delirium, and if it's not a tool you've used before, highly recommend watching the videos because they do give a really nice case-based presentation of how you can use these tools in your own practice. The Brain Exchange is another really great resource. It's got tons of information, and if you click on the Resource Center for topics A to Z, if you're interested in assessment and diagnosis, they've got webinars, videos, handouts, anything to do with seniors' mental health and dementia. The Brain Exchange is an excellent resource in terms of having tools in your back pocket and working on your own practice. And another one here, too, is the Geriatrics Interprofessional Practice and Interorganizational Collaborative Initiative. And again, this comes out of the Regional Geriatric Programs of Toronto, but in putting this slide in, I went and double-checked to make sure it's sort of context-appropriate across provinces. And it is in that when you click on the different tools, it walks through the sort of the best evidence and assessment tools in each of those areas. So really nice resource here as well. And another one, if teaching and training is part of what you do in terms of working with social work students, this is one that I like a lot. It's the Portal of Geriatrics Online Education. So some really great teaching tools. You can go through cases. Even if you're doing professional development within your agencies, there's some really nice videos and scenarios that you can use here in terms of some of the expert-contributed geriatric education materials. I'm conscious of our time and want to make sure that we have time for questions and discussion, but I just wanted to point out here too that we actually have some pretty good evidence about the best non-pharmacological interventions. So mentioned before that we have really good evidence for talk therapies with older adults with signs and symptoms of depression, but I think where it becomes quite tricky is the feasibility. And so I'd say this is, especially relevant in the context of long-term care, but across the continuum of care as well, that while we might have good evidence, we don't often have the human resources or the financial resources to implement some of these non-pharmacological interventions. So I just wanted to point out this paper here by Dallas Seitz, who I mentioned earlier, as doing some great work around administrative health data, has this really great paper where he did an analysis of the non-pharmacological interventions for neuropsychiatric symptoms of dementia in long-term care. And again, what they found was, while there was, interest and willingness to use the intervention, so things like snoozle-in rooms or sensory carts, or massage therapy, or some of the Montessori activities, really good evidence that the feasibility became the most important barrier to implementation, and that was in terms of sort of the human resources. So if you're in a leadership position or if you're advocating for system change, I think it's really important to note that this is a place where we have knowledge translation issues. We've got really good evidence, but the evidence is often not implemented in our different systems and services. And so if you're interested in that evidence base, I would point you back to the different guidelines from the CCSMH. Really great evidence around depression, around delirium, and about responsive behaviors in long-term care. And there is a strong evidence base for much of the non-pharmacological intervention. I also just wanted to point out some of the innovations right now. I think we're in an exciting era around treatment, and I think a lot of it has to do with reduction of stigma, but also awareness that mental illness does not discriminate by age. It is a relevant concern across the age span. And so I've included you the link here if you're interested in some work coming out of the Center for Addiction and Mental Health, looking at some non-invasive approaches, so deep brain stimulation being one, in terms of relieving depression and also having an impact potentially on dementia and people living with schizophrenia. So some interesting work to keep an eye on out of CAMH. This is also an initiative out of Baycrest in Toronto called Cognicity, and this is, according to them, free, private, and clinically researched by Baycrest. And this is sort of exercise for your brain, to keep your brain active and engaged as a way to try to work on preventing some of the signs of cognitive impairment in the future. I think there's been some controversy with other versions of this, but they've got a team of researchers who have endorsed this. So that's something that you can use with your clients as a resource for them. And this is another one that comes out of Nova Scotia called the Fountain of Health, and started in Nova Scotia. It's now going national. And it's really focusing on that mental health promotion piece. So how do we support people's flourishing mental health as ways to keep people aging well and quality of life? So focusing on physical activity and social activity and drawing on the evidence around positive thinking and brain challenges similar to what we see on the Cognicity website. And they're now unrolling an app that is, individuals can sort of do some self-management around their mental health, but they're also unrolling an initiative for physicians and providers to use to sort of trigger them to be sort of recommending mental health promotion to their clients as well as other types of interventions. This is another interesting one to keep an eye on and a little closer to you folks out there than some of the ones I'm mentioning in Ontario. I also wanted to just include this, that I think we have some exciting things potentially coming down the line. I don't know if anybody has heard about the Dementia Village in the Netherlands. There's a great documentary out there called Dementia Care by Design, done by Nicole Gaudet, Gaudet. And she spent time at this Dementia Village, and it's a really unique way that they are responding and providing dementia care there. I think it really aligns with many of the values and philosophies of social work in terms of it being a town where it's really focused on dignity, autonomy, and normalizing what it means to live with cognitive changes. Quite a shift from our current system of long-term care. And I thought it was interesting, this summer our Minister of Health was there having a tour. So I thought that was maybe exciting to see how that might translate to our context. There is a dementia village that will be starting in British Columbia, but a little bit different than how it's run in the Netherlands in that it's going to be private. So the version in the Netherlands is part of their publicly funded healthcare system. Very briefly what they found. So people live in small home-like environments where they're involved in the cooking, they're involved in the meal preparation, they're free to walk through the communities. They have a pub and a store, and they don't have to pay for anything. It is an enclosed community, but the public also comes in to enjoy theater and the beautiful architecture. And what they've found is that this environmental shift, so thinking about environmental interventions, has actually improved satisfaction amongst residents, employees, volunteers, but also that they have seen a decrease in some of those responsive behaviors because people have a lot of autonomy and freedom to be outdoors and walking around. And for those of you who are working in long-term care, you have likely seen some residents who, at the stage of their dementia, often, are mostly stuck in their bed and unable to get up. They've never had, since 1993, they've had no residents who stay in their bed. So some really interesting pieces here about the potential for environmental interventions. Just to end here, I just want to talk about that geriatric social work is, one of the most rewarding fields to be in because we have such opportunities to improve the aging experiences for individuals. But there's also a lot of tensions, and I think that's important to acknowledge as well. Particularly when working with older adults and their care networks, there's often challenges about families having concerns about an individual's right to risk. and where family caregivers, want to step in to help, but sometimes that is potentially compromising the autonomy and dignity of an older adult. And I think we're in an interesting era here in terms of policy and legal frameworks, and certainly medical aid in dying being an example of that. This morning on The Current, I don't know if anybody heard it on CBC, talking just about this in terms of our right to access things like medical aid in dying if we live with mental illness or cognitive impairment. So I think we're in an era where there's some interesting things happening and will continue to be so in the future. Just to end, I want to highlight that many people with mental illnesses say that it's harder to live with the associated stigma than the illness itself. And I had the opportunity to do some research for the Mental Health Commission of Canada. And unfortunately, what we do know is that healthcare providers often have very high levels of stigma. So despite the fact that we're there helping, we carry stigma with us. And so for all of us in helping roles, it's important that we are examining our own biases and values to make sure that we are providing the best care that we can. And recognizing for older adults, they experience ageism along with the stigma of mental illness. And so I'm not going to play this video clip. I'll skip through it, but it's available for you. And this is Rosalind's story. She participated in the anti-stigma initiative that we did. And if you're looking to bring the voice of an older adult into your training, she's a wonderful spokesperson and advocate for how important recovery is and thinking about reducing stigma in late life. If you also want to do a little bit of work around what stigma is, there's a great online course available through the Centre for Addiction and Mental Health, and also an outstanding module through the Mental Health Commission of Canada that at the end you can get a certificate showing you've gone through it. And again, if any of you are training and working with students, I highly recommend you building this as part of your teaching with them. I have all my students complete this, and they certainly learn a lot doing it. And there's some really helpful videos and people with lived experience talking about what it's like to experience stigma from those who are intended to be helping you. And I would say, too, that stigma and ageism, that intersection is really important. And when we think about how to help people, bring people into services, if they have a negative experience coming in, either ageism or stigma or any of the other isms, they're less likely to come back and seek help. So really, it's important for all of us to be ensuring that the environments that we work in are creating safe and inclusive spaces to best support the older adults and their families who we work with. So sorry to rush there a little bit at the end. I want to make sure that there's lots of time for questions, and I'm just going to leave up my contact information as well if there's other questions that you have after this session ends. So I'm going to turn it over to you, Annette, then, if there's questions that you think we should try to get to.
Okay, wonderful. Thank you so much, Kim. We do have a question from someone who indicates that they work with adults living with complex mental health issues, many of whom are aging. And what resources would you suggest to better understand the unique experiences of this population?
It's a great question. So one of the best models that I am aware of comes out of sort of central eastern Ontario, and it's a psychogeriatric ACT team, and they've done a lot of really great education around this sort of complexity and layering in aging. What we often find is that the services and systems that have supported people throughout their lives, if they live with complex mental and physical health concerns, all of a sudden when they turn age 65, they have aged out of these services that have supported them throughout their lives. And so I would say there is a gap in how much evidence we have available, and this PACT team, the Psychogeriatric ACT team, is one of the best that I've seen, and I'm just trying to go into the archives of my brain. I think it's through South Lake Regional Health, and there's some great work there. I also think that this is something that is getting more attention recently in the last few years, and I think the different associations and agencies are doing a better job now at recognizing they need to start thinking about aging. So certainly I've had conversations with folks from the Schizophrenia Society where they are trying to add some resources around how aging and aging processes add to the complexity and have some particular considerations around how medication might need to be changed as people are growing older. But I would point you to the different associations. And also I think the Mental Health Commission of Canada is doing some work right now trying to address this complexity and aging, trying to bring some of the evidence together. So in March of 2019, they should be releasing some additional resources around seniors' mental health and illness. Mm-hmm. The other places I sort of say are go-tos are certainly CAMH, Centre for Addiction and Mental Health. And again, it's a little bit Ontario-centric, but their resources are relevant. But Baycrest, to me, is also one of my go-to resources. When I have a question, I often look to see what they're doing because they are often sort of one or two steps ahead of many other folks.
The same person just emailed or just texted in. What does PX stand for again? The team again?
Sorry, the Psychogeriatric Assertive Community Treatment Team. And so the assertive community treatment is a model that's often used, and I apologize if it's not something that's within your context, but it's sort of a community-based model to support folks with the most intensive sort of care needs, particularly those with severe and persistent and complex mental illness. And so, resource intensive but very strong evidence base to support this model of care to support people living in their community. And unfortunately, they're often for adults. So typically we would see people served with these different assertive community treatment teams between the ages of 18 and 64. And now that people are living longer, as they were aging, they were finding that those teams weren't equipped to best support them, and so they were now sort of being lost, not having services anymore. So the psychogeriatric model is one that I thought was, one of the best I've seen, really exciting and promising. And yes, I have to admit I don't know if it's expanded, but it's one that I often point folks to as being a really innovative model of care.
Okay, thank you. We have another question related to antidepressants, and do you think there's an overuse of antidepressants among older adults who may be experiencing normal grief and loss, for example? So is there a jump more towards the pharmacological solutions versus the counseling or social programs? Your perspective on that?
I think it's a great question, and I am answering from my non-medical perspective. So I want to be really clear that I'm sort of just answering this based on my own perspective. I think that it's a complicated issue, and I think part of it is the way our current healthcare system is delivered. So for many older adults, financially they have more access to medication through their provincial drug benefits than they do to have psychological therapy. So while I think that there may be a jump to prescribe, I think often people want that. So, often in geriatrics, we say, there's a pill for every ill, and that people often want to have a pill to help with their ills. And so I think that we do see active use of antidepressants, but there is actually good evidence for antidepressants. But the best evidence is antidepressants along with talk therapy. And I think that there are real logistical challenges for some people accessing psychological services in the community, particularly those that are sort of outside of what is in the insured health plan or for people who don't have extended health benefits. But the other side of it is, I think part of the removal of the bereavement piece in the DSM was that, we were waiting too long to help people who were experiencing, it may have been depression brought on by sort of situational context about grief and bereavement, but we were waiting too long because we were, sort of giving people the 6-month period and then at a certain point saying, okay, maybe now we need to be stepping in. So the message that I give to my students is, of course, there is typical grief and bereavement, and we need to equip people to have the skills to to have that resiliency, the mental health capacity to be able to respond to that difficult situation, and to make sure that we have social supports in place for people. But we also don't want to wait because we don't want people to have low quality of life as they're aging. And sometimes I worry that, previously with that bereavement clause, we waited too long to offer supports to people. So, sorry, it's not the most clear answer. I think it's a really complex issue, but I think there are systems pieces that also influence the use of medications more than other things, or in combination with other things.
Excellent, thank you. This question is related to a slide that you would have presented earlier around some of the research. And was there any possible reason provided for the large increase in dementia that was seen in one of the studies? I think they said 83%.
Yeah, so I think what we mostly attribute it to is the fact that we do have an aging population, and where we see the most significant increases are those 85 plus. And while dementia is not a typical part of growing older, we know that age is a risk factor. And so because the biggest growth in our aging is in the 85 plus, that is a big contributing factor to why we have seen an increase in the rates of dementia. I should have included this too. I will say there's a really interesting paper that came out in the 2017, the July issue of The Lancet, which was around sort of what we can do to prevent cognitive impairment. And I think too, the piece for me that was most interesting that I circulated to all my family and friends was around midlife hearing loss. And so, what are the things we can be doing earlier on in life to prevent or to minimize risk for cognitive impairment? And, we know what's good for the heart is good for the brain. So certainly exercise and diet are important interventions, but some of these other pieces that we didn't have the evidence base for before, we now know that addressing hearing loss is a really important protective factor. So I'll be curious to see how those rates change. There's been some evidence that dementia rates are declining actually, and I think the more we know about upstream prevention and mental health promotion, that might sort of shift and influence the rates in the future.
Mm-hmm. Okay, thank you. And we have another last question, I guess, before we'll wrap up. In terms of unintentional functional decline in long-term facilities and thoughts around that in terms of the mental health piece.
Sorry, can you say that again?
In terms of what are your thoughts on unintentional functional decline in long-term care facilities? Any impact that might have on our mental health?
Yeah, I mean, we do know when we look at, for example, there's some initiatives around senior-friendly hospitals, and so I think some of those principles can translate to long-term care. Getting people up and moving is so important in terms of function, and we know that, even a brief period of immobility can reduce function. So I do think probably unintentional functional decline happens in long-term care where people are not, doing as many of their activities of daily living or not having the opportunity for as much engagement. And so certainly I think that does happen. And there is a relationship between functional decline and mood. So I think that, there's opportunities here when we're thinking about that promotion piece, the mental health promotion, that there are opportunities to be thinking about the ways that we can continue to focus on active engagement, physical activity, and preventing functional decline in people in long-term care. And I think that would have an impact, down the line for people's mood, behaviors, and cognition for sure. We're seeing that even the Alzheimer's societies are doing things called Minds in Motion, and we've got some of our students who are out being trained to do physical activity as part of the ways to, again, keep people functionally well, but also with thinking about the impact on brain health. So I think absolutely there's again, I think these are a lot of the complex system issues around long-term care where we often don't have the human resources that we might like in our perfect world, where we would be able to offer, more one-to-one work with residents.
Mm-hmm. Okay, well, thank you. That's all the time we have for questions, so I'm just going to wrap things up. But I do want to thank Kim for this stellar presentation and for sharing her knowledge and experience and expertise with us today. It's just so beneficial when we can come together to enhance our knowledge and understanding of issues impacting on our clients. And Kim certainly covered a lot of information and shared a lot of important resources related to seniors' mental health that we can use to enhance our own practice and work with seniors. So again, Kim, thank you for joining us. You're situated there in Ontario for this excellent presentation today. It's truly appreciated. And again, the recording of this presentation is going to, and the slides, and will be uploaded to the NLASW website for your reference in the future. For those of you who have attended 75 minutes or more of the presentation, confirmation of attendance should be available now by clicking the yellow icon at the bottom right of your window. And I also encourage everyone to complete the evaluation that's going to appear on your screen. So on that note, thank you so much, everyone, and have a wonderful day.